And we'll get started. Okay, so let me pull up my notes here. All right. So hello everybody. For those who don't know me, I'm Sarah Connor. I'm an organizer here at Planned Parenthood of Central and Western New York. I'm based in Rochester, New York. I'm joined by Deborah McDowell-Hernandez, who is our Senior Director of Public and Community Affairs. And we are joined by our very special guests, our panelists, Dr. Linda Clark and Sherita Bullock, who will be introducing more and hearing a lot from today. So stay tuned for much more from them. So we're going to hear from Dr. Clark, then we're going to hear from Sherita, and then we're going to have time for Q&A. So if you have questions, if you think of questions during the presentations, feel free to drop them in the chat and we'll get to them at the end. All right, so I wanted to quickly start by talking about why Planned Parenthood is invested in this issue of racism, public health, and how the US is failing Black mothers. Why does Planned Parenthood care about this issue? How does it fit into our mission? So at Planned Parenthood, our mission is to protect and provide healthcare and education that empowers individuals and families with respect, without judgment, no matter what. And we know that in order to fulfill that mission, we have to address the racism and the discrimination that stand in the way of maternal health care. So Planned Parenthood, for example, PPFA, Planned Parenthood Federation of America, has endorsed the Black Maternal Health Momnibus Act of 2020, which is a big suite of legislation that would address the racial disparities in pregnancy outcomes among Black women in America. And I wanted to quickly read a quote from Alexis McGill-Johnson, PPFA's president and CEO. So she said, "For Black women, becoming a mother shouldn't be a life or death decision. We need maternal health care that is compassionate, comprehensive, and unbiased, and we need policies that recognize the urgency to save Black women's lives. The COVID-19 pandemic and maternal health crisis have shown us how deadly structural racism is to our health. Planned Parenthood is committed to collaborating with organizations like Black Mamas Matter Alliance that center Black mothers in this maternal health crisis. It's time for policymakers to stand with, listen to, and trust Black women and pass the Black Maternal Health Momnibus Act of 2020. We are going to be sending up a follow-up email in the next couple days to everybody who RSVP'd for this event. So we will include information about the Black Maternal Health Momnibus Act, as well as some other local, statewide legislation that is on the table to address these issues. So keep a lookout for that. But, you know, Planned Parenthood, we believe that all people should have the right and the ability to make their own reproductive decisions, and that includes the right to have a safe and healthy pregnancy and to raise your children in a safe and healthy environment. So, you know, that's why we're invested in this issue on the national and the local level here at our affiliate. So yeah, I wanted to kind of set that foundation for us today. And with that, without further ado, I'm gonna pass it over to Deborah to introduce Dr. Linda Clark, who will talk more about how racism impacts public health. So take it away.
All right, thank you, Sarah. And for those who are just hopping on, again, my name is Deborah McDowell-Hernandez, and I'm the Senior Director of Public and Community Affairs at Planned Parenthood of Central and Western New York. And welcome, thank you all for joining us today on this Zoom call. I am going to introduce Dr. Linda Clark, and I'm looking at my notes so I don't miss anything because she has quite the resume here. So Dr. Clark serves as a senior health advisor at Common Ground Health, providing strategic counsel to Common Ground's initiatives from a medical perspective. She continues to work part-time as a practicing physician, as she has practiced occupational medicine for 25 years and clinical preventative medicine, with a focus on substance use disorders for the past 14 years. Dr. Clark also maintains appointments as a research assistant professor in SUNY Buffalo's Department of Epidemiology and Environmental Health and Public Health as an adjunct assistant professor in public health sciences at University of Rochester School of Medicine and Dentistry. Dr. Linda Clark is one of 3 co-founders and board chair of the Black Physicians Network of Greater Rochester, which supports efforts to reduce health disparities, mentors medical students, and raises money for scholarships. Active in community-based organizations and in the medical community, she serves on the boards of directors of Trillium Health in St. Joseph's Neighborhood Center, on the Committee to Eliminate Health Disparities of the Medical Society of the State of New York and the Monroe County Medical Society's Quality Committee. Most recently, Dr. Clark was appointed the chair of the newly formed Committee on Equity and Diversity with the Monroe County Medical Society. Honors for her community service include the Raymond L. Graves Beloved Community Award and the Woman of Distinction Award from Girl Scouts of Western New York. Dr. Clark earned her medical degree from University of Virginia, her master's degree in epidemiology from SUNY Buffalo, and her bachelor's degree in biology from Brown University. She is board certified in occupational medicine and in general preventive medicine and public health. Dr. Clark is married and has 2 children. She's actively engaged in her faith community and in her spare time. She enjoys spending time with family, reading, gardening, playing piano, and participating in book club, which I sometimes attend. So welcome, Dr. Clark. We are happy to have you here with us, and I will let you get on with your presentation.
Thank you so much. The book club is one of my favorite things, but I rarely get to go or get to read the books. So I gotta make that a priority. Let me just stop that for 1 second. Sorry. They had me practice, but I still didn't get it right. Hold on. Okay. Now I don't want to take up Sherita's time. I hope everybody's well. So my role today is to talk about the relationship between racism and maternal and infant health. And I would argue that along with everything else that we've been talking about, racism being a public health crisis, it is specifically a crisis situation for our pregnant moms, our infants, and our new moms. So I'm going to talk a little bit today, try not to have too many graphs, but I do like graphs, so bear with me. This is a quote from Dr. Fauci, because a lot of times I talk about racism and how COVID has really shined a light on how racism has impacted health. And he says here, health disparities have always existed for the African American community. COVID-19 is shining a bright light on how unacceptable that is. We will get over coronavirus, but there will still be health disparities, which we really do need to address in the African American community. So I wanted to level set a little bit so we're all talking the same language. First, I want to talk about racist. What does it mean to be racist? And I quote Ibram Kendi all the time when talking about how to define that. So racist are policies and ideas that create or justify racial inequities. So a lot of these were done, many years ago and not intentionally, but still have impact today. So
I don't think you can see your screen. Am I the only one?
Oh.
Yeah, I was just going to tell you, I can't see your screen.
Okay, let me try. Here, I'll try again. Thank you
Okay.
for interrupting.
Good.
Okay. Every time I hit that.
Sorry to interrupt.
So can you see the bubbles of,
Yeah.
Okay. All right. So we talked about, actually, let me go back. In terms of what it means to be a racist. A racist is someone, they don't have to be necessarily white, but they're being racist when they endorse a racist idea or policy. So I don't want people to think I'm just talking about folks running around with white sheets and burning crosses on lawns. This is sometimes me in my own practice, not realizing that something that I'm doing or endorsing might have a negative impact on a Black person. So what are the different levels of racism? I had a colleague today say, this is a very busy slide, but I love this slide because it's the root of my talk. So if you look at the outer shell, we're talking about structural racism, and these are ongoing inequities that are perpetuated in society and largely accepted. Institutional is more discriminatory policies and practices within organizations, within institutions, like healthcare systems. Interpersonal or interactions between individuals that are influenced by racial beliefs. And then internal racism is, what we feel based on race, and it's within the individual. But all of these are largely influenced by the other levels of racism. This is a little blurry. This is my first slide on maternal morbidity and mortality. This is taken from New York State Department of Health. And this is looking at severe maternal morbidity rates by race. So in this scheme, red is Black and blue is white. The higher level number indicates more severe outcomes. So this is over time from 2011 to 2018, where there's a consistent gap for Black women with severe maternal morbidity rates. It's consistent over time, and it's consistently quite high compared to other races, but especially for white women. Bringing it a little more locally, this is our city of Rochester, and this is what we call a focus area, a target area, which is the highest concentration of Black and Latino people in our city. Okay, and just hold on to that for the next slide. This slide looks at premature birth rates, another indicator of poor outcomes that we look at. So our focus area shows that these rates are often higher in the focus area compared to the other parts of Rochester, and even more significantly to the suburbs in Monroe County. At all levels, Black, except this one, but Black and Latino women are showing disproportionate rates of premature birth compared to white women. So that is very important. So race matters, place matters, the combination matters. And at this point, I want to talk a little bit about what, when we talk about disparities, when we talk about health inequities, what exactly do I mean? So health inequities are unfair and avoidable. Illnesses and death that are linked to income, race, other factors that are largely hidden from the public eye. So I think oftentimes we think, oh, it's just the medical care that they're getting, or it's how the doctor prescribes. It's what happens in the medical office. But those resources that we need to put into communities that have not had as much resources are oftentimes not in a pill bottle. They're other places, which I'm going to talk about a little bit. So this is WHO's definition, World Health Organization, which unfortunately looks like we're pulling out of, hopefully not. But the health inequities are differences in health status, or in the distribution of resources between different population groups that arise from the social conditions in which people are born, grow, live, work, and age. I love this graphic. This shows that actual healthcare, the traditional healthcare that we think about, that in the doctor office type of stuff, is only 20% of a contributor to your overall health. So it's those socioeconomic factors, those physical environmental factors, the health behaviors that all weigh heavily on your health, more so than what I can do in my office. So that's important. So I'm leading to the part of explaining of why racism impacts health. So this slide shows social determinants of health. And I think most of us are familiar with those terms now, those non-medical things that I just mentioned. But racism impacts all of them, whether it's healthcare system, whether it's economic stability, whether it's where you live, whether it's your education level, the food that you you have access to and eat. Racism can impact all of those, which impact health. This slide talks a little bit or shows the importance of socioeconomic status with premature mortality. So you're dying too early. So the SES1 is the lowest socioeconomic status. Those are the people who make the least money. And the SES5 in this scenario are the people who make the most money. So you can very clearly see that you have more life lost, earlier death when you are poor. So poverty impacts your birth outcomes. So back down to that lowest quintile, the SES1, the people who make the least money have the worst birth outcomes. So 12.7% preterm versus 9.2% in SES5. It's markedly different in that lowest quintile. So the thing that's so impacting is that now you also have to understand that Blacks and Latinos are way more likely to be poor. So you have this economic driver, this being poor drives your outcome, and it's disproportionately so for Blacks and Latinos. But that's not the whole story. And this slide is always very interesting to me because this shows Black and white back to our years of potential life loss, that early mortality, dying too soon, more likely to happen for both Blacks and whites at the lowest socioeconomic status, but there's still quite the gap between Blacks and whites. The interesting thing about this graph is you look at the highest socioeconomic status and you'll see that Blacks still have a worse outcome than whites who are the poorest. So how do you explain that? And the way we explain that is racism. So we're thinking about our bubbles, our different levels of racism. When we look at that outer bubble, the structural and societal inequities or inequalities, inequities, I'm going to use the correct term, lead to these large disparities, these large differences in health outcomes. So this is just a slide demonstrating different chronic diseases like high blood pressure. So if we look at this first graph on the left, we see that Blacks are 490% higher risk or at avoidable inpatient hospital visits due to high blood pressure. I mean, that's mind-blowing. So, similarly, looking at diabetes, looking at asthma, these are preventable hospitalizations or emergency room visits that are so much more impacted in the Black community than the white community. And I know this is a slightly busy slide, but not as busy as Sherita's going to give you later, so you'll thank me. But this is just a few examples of institutional racism and how they might undermine health. So one might be employment. If Black people are not paid the same as white people, if they're not as likely to be hired, those financial challenges of being healthy is a lot harder when you have limited resources. And plus it's the toxic stress of financial strain. For any of us who've ever had, times where you weren't sure that the bills weren't going to get paid or your kids' tuition wouldn't get paid or whatever, you understand that's a stress on you physically and emotionally. The second example, and these are just examples, there's housing. And a lot of us understand the history of redlining in our community, but we have a concentration of poor people living in that focus area that I showed you earlier that also happen to be Black and Latino. But housing instability, another source of stress and strain. They made me that, you know, you live in a neighborhood that's way far from the hospital or the nice, you know, health centers. And then there's discrimination by health providers. And it's very clear, and they've had a lot of evidence that shows that Black people do not get the same treatment as white people. Some of that is due to historical, you know, educational issues. You know, some is you know, there have been studies that show people who are in the medical field and studying in the medical field still have racist ideas like Black skin is thicker than white skin, or Black people don't feel pain as well. And, you know, this knowledge that you're treated differently has eroded the trust of the community for healthcare providers and healthcare institutions. So I think no, I did not talk about this. This is specific to maternal and infant health disparities. So we're seeing big disparate outcomes. You know, if we look at the left, we talked a little bit earlier about severe maternal morbidity and looking at the New York State numbers. These are local numbers, but so 51% higher in Blacks and whites. Infant mortality, 214% higher in Blacks than whites. Preterm birth, 77% higher in Blacks than whites. So how, you know, how does this happen? What's the biology? Okay, that is a whole nother talk and lecture, and you probably need some other white coats to talk to you about it. But I want to talk about just two concepts. One is weathering, which a lot of us have heard about, but weathering relates to aging early. So in this slide, we have a cell. In the middle of the cell, we have chromosomes, and chromosomes are what programs us to be who we are and look how we look and some of our health outcomes. So these chromosomes are made of DNA. The very tips of these are called telomeres, or some people say telomere. I say telomeres. As telomeres weather, they age, and as they age, they stop reproducing. So over time, you know, for a while, you know, your cell reproduces and keeps making, you know, that end part of the DNA, you know, it pulls out the end part of the chromosome. But as we age, it starts to divide less and less, and eventually it goes to where you have no telomere. So the telomere shrinks over time as we age. And what we have found is that in Black women, we have a genetic age based on weathering that could be 7 years more than a white person. So somebody who's 50 might really have the biology of a 57-year-old person. So that's one concept. Another concept is epigenetics. And epigenetics is very interesting to me. And I'm sorry, this is a little bit blurry. But epigenetics talks about what factors externally change your DNA and reprograms you. So, you know, in this particular picture, this is showing how this happens generationally. So, you know, what you eat, you know, the things you put into your body that you're exposed to. You know, I have a favorite picture of my mother standing on the Anacostia River in DC with these smokestacks behind her. And I always wonder, you know, what was the environmental impact of that on her life health-wise? But what's interesting is you look at things like stress, racism can impact the biology of your genetics. So that might be, you know, just little chemical changes, little deletions, little additions that all of a sudden reprogram you to be different, and your children to be different in ways that are not healthy, have worse outcomes. And this happens to us even after we're born. So children have stresses and traumas and other, and in eating and other things that are external but can also change their development over time. So trauma in a child can create dysfunction in an adult. And I think this is my last slide. And this is really talking about equality versus equity. So in this picture, we have this white man and this black woman who are going to run the same race. They're going to run the same distance, but the inequity of it all is on the black woman with the ball and chain and all these obstacles. That is how racism impacts health outcomes in Black Americans. So that is just setting the stage to help understand why we feel that racism is impactful on the health outcomes of Black people in our country. So at that, I'm going to pass it on to my colleague Sherita after Deborah does her intro. Thank you.
Great, I can introduce Sherita next. Thank you so much, Dr. Clark. I think that sets a really good foundation for understanding Sherita's presentation. So without further ado, Sherita Bullock has been the Executive Director of Healthy Baby Network since February 2019 and an employee of the agency since 1997. Sherita is a vibrant and dedicated community advocate who has always cherished babies and never resists an opportunity to greet or acknowledge one. She is a Rochester native and a single mom who has lived and worked in Rochester for over 30 years. In 1994, she delivered a low birth weight preterm baby who stayed 5 days in the NICU at URMC. Inspired by the experience, she accepted a position at the agency, known then as Perinatal Network of Monroe County, and has progressed through increasing responsibilities to the executive director position. Sherita's focus, fueled by HBN's mission, is to give every baby the opportunity to be born healthy, and her work centers on the racial health and birth disparities surrounding pregnancy. She is affectionately known as the Baby Lady, for simply saying the thing in kindness and crafting innovative interventions based in listening to consumer lived expertise and collaborating to improve the systems we work within to provide care. She believes in the skills of bringing everyone impacted by an issue together to decommission barriers, and that the elimination of racial health and birth disparities is possible with the right collaborators and strategies if we work with our entire community. Each of our lives and those of our descendants depends on it for babies, their parents, and our entire community. So with that, Sherita, I will let you share your screen and take it away.
I was just about to start talking without unmuting myself. So I want to say thank you, Sarah, and to Planned Parenthood for having this very important discussion and centering on this, and then really helping us to dive deep into the conversation. And what I really hope will be an opportunity as well to have some conversation and some dialogue around some of these topics. I'm gonna also, and so I'm gonna start off with an ask. I recognize that in the day of Zoom, many of us are multitasking or are in all kinds of seating positions and locations. I'm gonna ask that those of you who can, please turn on your camera. One of the ways that I think is foundational to really right setting and, as our governor would say, building back stronger, is really around focusing around relationships. And relationships are what I believe the foundation of really addressing some of these issues and beginning to move forward. And sometimes they're started as easily as looking into the screen and seeing a smiling face. I'm one of those presenters who likes to look at the faces of the people that I'm presenting to. And so if I see questions or this look like, I don't think I really believe that part, it'll help me stay a little longer on that point. So to help me and to encourage relationship building, if you all, those of you who can, would turn on your cameras, I really would appreciate that. The other thing that had not occurred to me to do, but I think is completely appropriate, is that we're going to talk a lot about Black maternal mortality and morbidity. And I think that in doing that, I want to center us all on the lives of Black women who've been lost prior to and since the pandemic. And I think one real easy way to do that is for us to just take a moment of silence, thinking about the moms who went to the hospital pregnant and are not able, won't go home with their babies and their families, and to think about all of the ways and the drivers that led to that. We're going to center on them, we're going to talk about them, but I think it's also appropriate to just take a moment of silence. So if you would with me, let's just have silence. Thank you. I want to also say that this work is very personal for me. There is so much passion that is bound up in it. I'm sure you will hear my passion as I work through my slides, and will understand, I hope, at the end why I am so passionate, having heard a little bit about my own birth experience, but really in talking about, my daughter is now 26 years old. I take a breath every time I say that. I can't believe it. But how in those 26 years, largely our systems and our structures have not changed, and more importantly, are moving the wrong direction. So we have more maternal death and more maternal morbidity. And so the morbidity, or these sort of near misses, are profound in that they are learning opportunities for us and opportunities for us to improve and move forward from here. So in taking a moment to frame how I've constructed my presentation, is I'm going to spend a little bit of time talking about where we are. So, what is our current landscape looking like in terms of Black maternal mortality and morbidity? Not to share more data, because Dr. Clark has given us the data, but to really talk about the stories within what that data represents. And then a little bit about our pathway to how we got here. And then most importantly, spending some time talking about what we're doing and what is our approach moving forward. And when I say our, I mean all of our collective approach moving forward, because I believe that there is work for all of us to do. And if I do my job well, at the end of my presentation, you will believe too. So, Black maternal mortality and morbidity. In April of 2017, we first began to see a lot of articles in the media talking about the disparities in Black maternal mortality and in maternal mortality overall. I could sort of step back and say that overall, when it comes to birthing, we do not do well. And so when we dive deep into why we're not doing so well and for whom are we doing the worst, that is how we come to really talking about Black mothers and their families. And so pictured here is Shalon Irving. Shalon Irving was she was a military professional. She worked at the CDC. She was highly educated. She knew her body well. She was engaged in all of her prenatal care, did all of the target behaviors that we would want mothers to do. Attend your prenatal appointments, eat healthy, try to control for your stress, and really focus in on resting and preparing for the birth of your child. And even still, with the best medical care and all of that information, shortly after the birth of her daughter, Soleil, who is pictured in the center at the breast nursing, that's one of the other things that I get really excited about. With her mom, Wanda, Shalon passed. And one of the things that, as we center on understanding why is it important to talk, in addition to the data, to tell the stories of moms, we want to understand that, one, for every data point, that's a family, a mother, a father, a child, and a whole group of family relatives who are represented, and that there are stories there, and that within those stories, we understand when we can listen and really dive into the root causes and all of the contributors, what our best information is around how to stop what is going on. And so, when we look at Black maternal mortality and all the information around that, we talk a lot about consumer experience. And we say, oh, if we listen to patient experience, I want to start a campaign to swap out the word experience for expertise. Our patients, our consumers, our mothers, our fathers are experts in their own experience. And as community members, as medical providers, as health and human service providers, as educators, wherever you find yourself along that spectrum, if we can acknowledge in the same way that we would say with a degree we're experts on whatever topic, that people who live their lives, who are involved in the day-to-day, are experts in their own experience. And we need to begin to acknowledge that in the care that we provide and change the seat that we sit in when we're engaging consumers, be they patients or whatever your terminology is in your field, and understanding what's going on for them, how is it showing up, and what's happening, that they are experts in their experience. So Shalon, knew early on that something was off after delivery. She was swelling, she was in pain, she was sharing that with her mother, she was sharing that with providers on her care team, and was being told it's the normal course of delivery. It's fine, you're okay. And she kept saying, no, something just does not feel right. And her providers were telling her, you're fine, you're fine. And she then began to complain about issues with her heart. It starting to beat very rapidly. She began to, say, I don't feel right. I feel like I can't catch my breath. And she was sharing all of these things, and her providers, continued to tell her, you're fine. It's the normal course of delivery. You're fine. And then she slipped away. And by the time they realized that she was truly in crisis, she was gone. So we hear this story and we hear some of the intricacies, and oftentimes when we talk about pregnancy, health, and birth outcomes, we go back into our minds these profiles that we hear of women who are poor, women who have limited access to resources, be they quality medical care or information about conditions that they may have, information that is really screening information that there are other things that are going on in their bodies. And we sort of say, so if we could just provide better care, if we could just, get women into care earlier, if we could just do something about the doctors that they see or the social determinants of health. I was struck by the 20% being medical care, but when you are a mom who's in the hospital, it sort of flips because you're really dependent on your medical providers to cue into the things that are going on. And I want to say to you all, as we're having this conversation, that it's important that we hold on to sort of very different places. So oftentimes we talk about patient and provider relationships without acknowledging oftentimes that our patients or our consumers are experiencing those relationships very differently than what our providers are experiencing them. So you might talk to a provider who says, I have a great relationship. She comes in to every appointment. This is great. She's, showing up on time. And you may talk to a mom who's sitting on the other side of that who would say, yeah, but my provider doesn't really listen to me. And every time I go, I see a different provider. And I have to tell the story all over again as though it's not somehow captured somewhere in something that they're reading. And I want to tell you that when I first started diving into maternal mortality and morbidity myself, I had that very same thought. And so as we would sit and we would talk to moms who had experienced what we call near misses, so very bad things happened, and then they were able to recover and to survive that. And then the family members of women who very bad things happened to them and they weren't able to survive it and then they passed away. What we heard was our provider didn't listen. They didn't hear what we were saying. We didn't know medical speak, so we couldn't say that that there was probably a blood clot that was in her lung that was disturbing her breathing, but we said she can't catch her breath. She's having a hard time breathing. She seems like she can't get on pace. And that just got worse and worse and worse. And then she was gone. And then we talk to medical providers and we say, when we talk about maternal mortality and morbidity, tell us what is going on. And medical providers told us, well, in many of these cases where we have seen deaths, these moms had underlying medical conditions that either were not addressed until she presented for prenatal care or were never addressed throughout all of her prenatal care. She delivered and then a complication arose, and as we were trying to address them, that medical condition was really the cause of her death. And I come to this and as you all know, I'm not a medical provider, and my daughter's 26, so I'm not a pregnant woman, but I'm a reasonable woman, and I can follow logic going, how can these two things that are so very different coexist all at once and cause such dramatic and repeated death without us being able to get ahead of it? What is going on here, and how do we really, really understand? And so in listening to moms, we say, okay, so we need to be able to provide better screening. And we need to be able to somehow amplify the voices of those moms when they're saying something isn't right. To ask follow-up questions like, what do you mean by something isn't right? What are you experiencing? I'm having a hard time catching my breath. Okay, describe that. Are you able to get air in and it's not going? Do you feel like you can't get air in? Do you feel like your heart is racing? And then being able to get medical providers engaged very early when those early symptoms are happening. To be able to understand this mom has high blood pressure, she's taking medication prior to pregnancy. What are the things that we need to be focused on? What do we need to be watching? What is our cue that something is going very wrong and we should immediately get her to the hospital? And following that same sort of course of framework all the way through mom's care. Who are the people that we can engage? Who else can be in this conversation and can help provide either information or access to the doctor or doctor speak or whatever it is? And then we go to the other side and we say to our providers, this is what we're hearing from moms. What's the information that we need to be telling them? Who else engaged on the medical team can provide this information? What do we do for moms who feel like they're not seeing the same provider? How do we create some stability in that care? So along the pathway of just giving you yet another example of this not being moms who, this not only happening to moms who have limited access to information or resources, we reflect on Serena Williams. Serena Williams is an athlete. She relies on her body to perform. She knows her body intricately. She knows what her health history is, all those things that we would construct in a profile of a mom who would be most at risk for an adverse outcome or death, right? So medical status. Serena knew that she had issues with her lungs and with blood clots. Serena knew and had the best medical care. Serena happens to be married to one of the richest men in America, a tech startup of Reddit, who paid for her medical care out of her pocket. There was nothing that should have been out of her reach. And yet, following the delivery of their daughter, Alexis, she began to experience trouble breathing. She knew exactly what tests she needed. I need to have an x-ray of my lungs. She knew that she needed it with contrast. And she told her provider team that. I need to have an x-ray. I need it with contrast. She called out the name of the procedure. Her medical team knew that cost was not a concern, right? They finally, because her breathing got so bad, and for whatever reason, at a particular moment in time, she was in her room alone. When her breathing got so bad that she could not sit or stand, she had to crawl to the end of the bed using a chair to get out of the bed to go out into the hallway to stop a woman who was going down the hall, a nurse. She said to the nurse, I can't breathe. She was clinging to the woman's arm. And in that moment, that nurse was able to get a medical provider to come in, and they ran the test. Even still, with all the information that they gave her, they ran the test without contrast and had to repeat it at her husband's begging. And one of the most profound things about this experience was a quote from her husband, who said, "Here I am, one of the richest white men in America, with the thought that my daughter could potentially grow up without her mother because of things that I have no ability to do anything about." And so Serena was able to finally get the testing that she needed. She was able to get the treatment that she needed and has survived. She has gone on to fund other tech startups around maternal health and to really get involved in this issue to try to do, to get people to be motivated to act. So what are the causes and the drivers? This is a busy slide that Dr. Clark was talking about. And I think, you know, to Sarah's point, when we were going through my slides, if you just take a moment to step back and look at all of the barriers that are listed here, it's a lot, right? And so some of you might be tempted to wonder, well, with all of these barriers, how do we ever have a hope of doing anything better or anything different? But if we dove a little bit more deeply into what some of these are and what some of the drivers are, right? If we started, and I don't know if you all can see my cursor, so I'm circling around the very first one, generations of mistreatment and abuse of Black women. And so when I think about generations, I go back to, you know, the father of gynecology, who's considered to be James Marion Sims. And I think about the atrocities that this man did as he was crafting the tools that, you know, today are still in use, that are used in gynecological care and in birthing and in delivery. And recognizing that a lot of the tools that he did, he practiced on slave women, Black slave women. And recognizing that and knowing the history of how these things came to be and the fact that many of them are still in use, and then holding and carrying all of that knowledge as I'm, you know, going in to receive care. And I am, you know, not an anomaly. This, you know, it's common information. Almost anyone can Google James Marion Sims, but also, you know, we're not only talking about uneducated women. We're not talking about women who haven't had access to education and resources. So, you know, almost when you're looking at racism as a driver, we really are, in many cases, centering on African-American women who are educated and high-income earners, who oftentimes are one of, or perhaps the only, African-American in their professional sphere. So in their workplace, in the conversations, in the boardrooms, where these conversations are happening. We take a moment to center in on structural racism and, you know, reflecting on the slide that Dr. Clark had and thinking about how within all of the care that we provide, we are interacting within systems that were designed, and as a consequence of that design, limit people's access and ability to care and to be healthy. We don't do a really good job in talking about issues around race or ethnicity or our own bias. And we all have bias that's at play. The issue is that some of us are providing care with bias at play that has been unidentified, unchecked, and we have no tools to identify when it is at play and then what to do about it. So, you know, asked very broadly, what is the impact of racism on maternal care? It's death. That's the impact. And then the question for me becomes, are we willing to accept that? Are we willing to accept that pregnant women go into hospitals afraid to deliver babies because of their fear of death? Are we willing to accept that we have an escalating Black maternal mortality rate in the same community, within the same systems, that we have international recognition for the tools, the strategies, and the interventions that are being developed? Are we willing to accept that? I talk a lot about sheltering in place during conversations around race and ethnicity. Sheltering in place, I will acknowledge, has a whole different context now in light of COVID. When I first started talking about it, not so much. But sheltering in place is this thing that we do when there are conversations around race or ethnicity, and we reflect back to the last time it went really bad, and I'm afraid, and it creates fear about, you know, will this person still be a partner? Will this person still be a friend? Will this person still speak to me after today? Will I still be invited to tables to collaborate if I share this, or if I say the thing that's on my mind, or that question that I really need to ask, but I don't, because I don't want someone to get angry. I don't want someone to yell at me. I don't want to walk away feeling like I've hurt someone. So we just don't have the conversation. We don't have it well. We don't learn how to have it, and we don't say the thing in kindness. I put that in my bio on purpose. Say the thing in kindness. It is a skill. But I believe that if you follow the first thing that I talked about, working on relationship quality, that in the confines of a good relationship, and a good relationship means that you put in the time to do the work to be able to say the thing that might be hurtful, but you know how to say it in love because you know something about the person you're talking to. And if you can say it in love, and if you can say it in kindness, even though it might be a hard thing to say, the person that you're talking to, who you put in that work to have that relationship with, can hear it, and you know what, might be able to say the thing back that gives you the answer that you need. So we got to do better about that. We've got to, really address our systems and talk about, are we centering on the thing that we say that we are? We're focused on improving the health and birth outcomes of Black women. Have we centered on them? What do we know about Black women? What don't we know? What Black women are in our sphere of influence? Are we going to talk about Black women and look around the table and there are none present? Are we going to talk about Black women in the community, or Black women who we provided services for, and then look around the table and there are none present? We got to be really honest about acknowledging the legacy of chattel slavery in America. And this is another thing that a lot of people don't want to talk about, but unless we are honest, and we can get really honest in talking about it and acknowledging it for what it is and what those causes and contributors were to today's health status, then we don't really have a whole lot of hope, And what's happening, here is the hope, because there is some hope in this. What's happening is that there are small pockets of people who are honest about it and who are willing to talk about it, who are coming up with crazy interventions that are really showing dramatic outcomes and evidence. And so we've got to be honest about that and share it. We've got to talk about white fragility and white privilege. Not in ways that demean and silence people, but in ways that provide information and tools around how to have that conversation so that we can understand what its cause and what its contribution is to today's healthcare practices. And we got to be okay about calling it out and learning what the tools are to address it. We have to get really clear about the impact of trauma, past and present trauma. And we talk a lot about the violence that's going on in our community, and we talk about, the curbside memorials that are happening. So curbside memorials are where in the place where someone was shot or killed, there are balloons, sometimes alcohol, sometimes candles, sometimes pictures that really just resonate on that. I was struck by, not too long after this whole COVID thing started, there was all this media attention because there had been a murder, and people had gathered at the site of that murder, and the comments were, look at all these people without masks, what's the mayor doing, da 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 da, on and on and on, without any recognition of the cultural significance of acknowledging the life of a person who is now gone and what their contributions were to you. And just taking a moment just to sit in that and remember and center on them. So whereas our conversation should have been, who can go out right now and give all those people a mask? Oh my gosh, we've lost someone in our community and people are grieving. How do we go and help them with their pain and grief? We were all focused on the wrong thing. Totally focused on the wrong thing. The absence of screening for oral health infections, infections within the vagina, diabetes, heart disease. Why? Because all of these things contribute to early birth and all of the other adverse consequences that we're talking about. And then preconception health. So before anybody is pregnant, talking about what is a healthy pregnancy. Having a conversation, do you want to be pregnant? Do you want to have a baby within the next couple of years? I used to start health education presentations with, how many of you are actively and correctly, and you know this for a fact, using birth control? And if you can tell me no, or if you are not sure, then nothing is certain, you know, so somebody right now is pregnant and doesn't know it, and somebody right now is a dad and doesn't know it. Some of you might want to step out and make a phone call. And people would get really uneasy. Some people would laugh, some people would go, ooh. But the point of it was to say, this is something that we have to focus in on. Conversations around preconception health can help people do birth planning in a way that then prevents or delays a pregnancy. Right now in our community, it used to be that the US hovered around 52%. And when we looked at the inner city populations of potentially pregnant people, 18 to 44, men and women, that unplanned birth rate, unplanned pregnancy rate was hovering really around 64%. And why is that? Because, and I would say either people have forgotten how babies are made, or don't have really good access to birth control. And the reality is it was a combination of both of those things. But really, oftentimes, to really, you know, again, going back to relationship being the foundation of all of this work, sometimes you have to make people laugh to get their attention, right? So utilizing all of those things. I'm going to move on because I want to have some time to talk at the end. So equality is really the way that we're providing care right now. Everybody's getting the same thing, and it really is driving our adverse health and birth outcomes. Why? Because as you can see clearly depicted on the left-hand side of your screen, I hope, or maybe right, under equality, is that giving everybody the same thing does not accomplish what our goal should be. So if our goal is quality healthcare and we give everybody one stool, in the same way this picture is for these 3 children to be able to see the screen, what we see is one kid has no problem, one kid has a mild problem, and then the third has no ability to see at all. So if we readjust to equity and say, we'll just give everyone the same thing, we'll adjust and give people not just the same thing, but what it is they need, unto each according to their need, right? And now we've achieved everyone being able to see. But here's the gotcha with this. We haven't achieved everyone being able to see. What we achieved was, for these kids, the 3 that we knew about, and understanding exactly what was going on for them in this moment, we achieved the goal of these 3 being able to see. What about the other children who will come, who this won't accomplish it? So then I take us to this next image where we see equality here. In the middle image, we see, you know, everyone is able to see, but in the third image, if we change the fence from being the picket fence to a metal fence with gaps in it, we've addressed the systematic barrier. Well, I love when I show this and people go, let's just take the fence down. We don't need a fence. Well, no, we need a fence. The fence serves a purpose. And if we were all gathered together, I would pause and I would ask you all for some ideas about what the purpose shows. But we don't really have the time or the ability to do that here. So I'm going to just tell you that the purpose of the fence is to stop the balls from going out of the diamond past the outfield, right? Without the fence, any of those kids or any child coming could get hit by that ball. So the fence serves a purpose. Our prenatal care, our medical care serves a purpose. We don't want to get rid of it. We want to be able to eliminate the barriers in ways that people get quality health care at the time, place, and to the degree that they need it, unto each according to their need. So why does it matter? Well, you all heard that I love babies, and you know, I used to say I don't pass up an opportunity to hold babies. You'd be surprised how many people don't want you to hold their baby in light of COVID, and I understand. But when we look at how our children are arriving here and what that first outcome looks like, and when more of them are looking like Elijah than Joseph, we really have an opportunity here to intervene. And pictures convey, you know, people say 1,000, I say more than 1,000 words. But when you look at a baby who's born and has the number of medical interventions as Elijah does, pictured here, then what do the number of interventions that he needs across the rest of his life look like? How many trips to the pediatrician? How many medications? How many things does mom have to navigate to get him to the pediatrician? How many times does dad need to miss work in order to be there and to help support? So our way forward. Now, this is also a busy slide, and I'm going to spend a little bit of time here because I really want to say that, one, all hope is not lost, but it does require us to do very differently than what we have been doing. And I think we have to get really clear about what we say is the value of people, patients, consumers, the ones that we are meeting in our offices, that we are seeing in our neighborhoods, the ones that we're coordinating care for. What is their value? And centering on the value of the fact that everyone has a right to, and fill the rest of the sentence the way that you like. But I say to have a quality life with the services and interventions that they need, to be lifted and supported in the ways that are significant to them, to be healthy, whole, and happy. That's how I value people in my interactions. So we need to be, number two, willing to reconsider everything that we've learned and respect people who have different opinions than us. And what is so important about that is when people think differently or have an opinion differently than you, what they are presenting for you is an opportunity to learn something new. Whether you ultimately accept it as your own or not, it's an opportunity for you. And we need to decide what we're going to do with those opportunities. We have to change the culture of the system that we work in, and we have to think about new alignment, new connections, and new strategies. I'm calling them networking strategies, but I would call these relationship precursors. So before you can ever get to know me or have a relationship of any kind with me, you need to spend some time getting to know me. You need to get to know what's important to me. What, motivates me to action, but what shuts me down. And then from that, then we can nurture a relationship and build from there. We need to think about these relationships in terms of lifelong impact, because while you might meet me in an office somewhere, understand that I will show up in a grocery store. I might show up in your neighborhood. I might show up in your school. I might show up at the where we pay bills at, and all of those kinds of things. And if we think about the relationships that we're building, or those relationship precursors, networking strategies, passing each other in the office, whatever, in terms of lifelong impact, and I know I've got to see you again, I might treat you a little bit differently so that the next time it's a welcoming experience. Get to know people in the community that you serve who are not likely to become either your patient, your consumer, someone that you're providing service to. Why is that important? Because if the only Black people that you know are ones that you provide services to, like it or not, your tendency is to think that all Black people move and think that way. And you can replace Black for whatever else. Abled, hair colored, personality, whatever. You have got to get to know people who are not likely to become your patients, because they expand your frame of reference for how people move and act. To understand that, we need to really establish, because we can't have anything until it's been established, and then nurture and cultivate relationships between providers and patients. When you change how you view the people that you serve, the care that you provide them will change too. I'm going to leave that there. Centering on consumers, so getting to know your target population and engage with them and their support people in their care and treatment plans. What do you mean? Well, how do I know who somebody's support person is? Who shows up to the office with them? When you tell them something that doesn't quite jive with them, who's the person that they go to and ask? So it might be a relative, it might be a best friend, it might be the person that they know who works most closely in the field that you are working in. Identify exactly who your target audience is and center and focus on them. If we are trying to improve the health and birth outcomes of Black women, then we have to center and focus on them unapologetically. And by that, I mean that if we say, well, we're going to improve healthcare for everyone, well, that's what we've kind of already been doing, and that's what has brought us to the disparities that we're looking at. So if we really want to change the health and birth outcomes for Black women, then unapologetically, we have to center and focus on them. Ask your patients, number 9, about their culture and how they express it. Everyone of one race or ethnicity who may have the same culture or the same cultural attributes does not express it the same way. I hope that is not new information for anybody on the call, no judgment. But what's so important about that is, while, you know, I may value relationships and my best friend will value relationships, how we value them and why we value them is different. And it's important that you learn that about each of us. Again, because if you're trying to motivate me to act, you need to know what my motivators are. Number 10, commit to not laugh or share jokes that disparage people in any way. Why is this important? Because every single time you do it, you create a disconnect between you and that person that only grows as time goes on. So it's just not funny. And nowadays, most people will check you whether they're in your conversation or around your conversation as they're hearing it. I'm promoting and utilizing community-based participatory research. So there is a mini researcher in me who has been involved in research projects. And what community-based participatory research does is it includes the people who you are researching. Oftentimes they're your professors and teachers, whether you know it or not. But it includes people who are on the end of the project, the receiving end of the work you're doing, right in the plan and right in the interest in how that intervention comes to be created, how it's deployed, how it's measured, and they bring information and insight that as researchers and as people who have been professionally trained that you won't have. And at a very fundamental basis, none of us knows everything. Everyone has something to offer and to contribute. And what they do oftentimes is provide sometimes those nuggets that really change the dynamic of what an approach is and how it works when you actually begin to deploy it. Recognize our community, number 11, as a valuable unit of identity. Our community has strengths, it has resources, it is beautiful, it is multifaceted. There are things going on that are already interventions in the making that are never called that. There are things that have historical context that are significant both to the past and to the present. There is value. And unless you really understand that, your approach from the very beginning will be all wrong. And you will come encounter with people who most uphold that value as one of their main priorities, who you will come in conflict with. And these people could be people who would support your work, but who will work against it because they recognize that you may not be there to do good. So after you can value it, then you can build on those strengths and the resources that exist, which is number 12. Black Lives Matter is a very interesting one because Black Lives Matter existed long before the moment of activity that we are in right now, many, many years before. But what has happened, and I said this earlier this morning, my point of reference would have been George Floyd until 3 days ago when Jacob Blake was shot in the back in front of his children because he was stopping to break up a fight that was going on in his community, something that under any other circumstance we would be heralding him for. He is now in the hospital fighting for his life. He is in critical but stable condition. But what George Floyd's death did, and what the shooting of Jacob Blake and all the others who have come before and those who have come since have done, is really ignite a passion around the Black Lives Matter movement and a passion around really advocating for change on all kinds of levels in our community. And so it's important that we center on Black Lives Matter. I know that there will be those of you who will say, well, what about White Lives Matter campaigns or Blue Lives Matter campaigns? I say the thing, I say it in love, I said it from the beginning, and I've come back to it many times. If your problem with Black Lives Matter is the fact that it's Black, supposedly all lives matter has been the way that we've always run our communities, and it's the way that our laws are based. But what we know is that those laws and the policies and practices of America and in Rochester play out very differently for Black people. And so this Black Lives Matter movement has centered on Black people as a way to say, let us look at what is going on as the centering point for how we craft any intervention or do anything else from this place. So again, this goes back to being really honest about the legacy of chattel slavery in America and all of the ways that that is manifested in our systems. Preconception health education, I've talked about. Transformative care is really going back to re-examining everything that we think we know, evaluating it against the lens of where we are and what we say we value, and then adjusting appropriately from there. Number 16, addressing racism in all the ways. And Dr. Clark went through them. I won't repeat them, that it shows up in our interactions, but also in our systems. And being okay about calling it out, because I'll wait till I get down to number 18. Having targeted intervention. So if we're looking at the risk and the highest risk categories that of the data that Dr. Clark was talking about, we're talking about African American and Latina women. We're talking about women with limited access to income and resources. We're talking about women who are either less than 25 or 35 plus. It does not go without note that the women that I talked about, both Serena Williams and Shalon Irving, and please understand that there are many. I keep some names on my board: Callista Johnson, Kira Johnson, Erica Garner, who is the daughter of Eric Garner, Shalon, Dawn Fleming, Shanice Mullings, and then there are others. But I keep their names where I can see them as a reminder for me to center on the women on whose behalf I say I work. And so we've got to get crystal clear about that. So these women were 36 and 37 for Serena and for Shalon. So there is something about that 35 plus age range that we need to center on. And then women who have or are at risk of these other conditions that are listed here. I want to point out and connect the fact that we point a lot of fingers around substance use and all the various substances. I would challenge us to step back and really have a clear understanding and conversation around why people are using substances to the degree that they are. I want to introduce the idea that many people who use substances are actually self-medicating, and that if we understood the causes and drivers of why people feel a need to self-medicate, then we could address substance use with a different lens and without the judgment that is really inferred in a lot of the care that we provide, not directed at any one organization or institution. I'm just making the statement broadly. Number 18, please do your own work. And this is so important. This is what I started to allude to when I was talking about the Black Lives Matter movement. I understand that there are many people who want to get engaged in doing something and finding what their lane is. What I'm going to say to you is that each one of us has a role and responsibility around addressing racism from wherever we are. Everyone cannot go out and be at a rally. And I want you all to understand, if no one has said it to you before, that all the people who support that rally are not at the rallies. Why? Because there are some people who are teeing up legal care for people who would get arrested. There are some people who are teeing up resources to pay for the legal care for those who are arrested. There are some people who are flooding social media with images of what's going on in the rally. That is a full strategy. It is intentful, it is strategic, it is purposeful. I say that to say to you, not all of us need to be at the rally. Some of us need to be at home coordinating care. Some of us need to be at home fundraising. Some of us need to be focused on showing others around the country what has happened. Find your lane, then do your work. And please do not lean on other people, be they people of color or women or people that you know have experienced traumatic situations due to racism. Don't lean on them. What you are doing is further injuring them, whether you realize it or not. I should not have to tell a story around pick a topic over and over and over again. Every time I tell it, it re-traumatizes. And that's not about whether or not I've done my work around it. It's around the fact that I have to relive it to retell it. And that causes hurt and injury to me. So there are many books. I mentioned this DVD because it was here from another slide deck that I was using. I want you all to know that I'm so serious about this work that I went home last night with 32 slides. You all only will have 12 of the 32 because I'm that passionate about this work. So to that end, I end with this number 20 to share what you heard today with someone, be it close family member, a close friend, but share it with someone, because in telling it is how it lives. That's why the storytelling is such an important part of the African American culture and the way that some people display it. I hope you caught that. I talked about culture, but I also talked about it's not shared and displayed in the same way all the time. So I could not be me as the executive director of Healthy Baby Network without talking specifically about some of the things that we're doing, because our programs really have been crafted in the way with the considerations of things that I have been sharing with you all. So information about perinatal, so that's surrounding pregnancy, prenatal through the postpartum period, and then specific birth preparation, so helping families understand what to expect when you go in to deliver and to birth, is education that we provide here. We do it in homes, we do it in the community, we do it through groups and other ways. We are doing outreach every day out into the community, even in light of COVID, and with COVID, social distancing, acceptable ways to connect with pregnant and parenting families that are not connected to care and who may not have medical insurance, to do referrals and make connections for them. We provide all kinds of maternal, paternal, child health education information. And we do that also in groups. We are doing them via Zoom. We have a Black Doula Collaborative. Doulas are an evidence-based intervention to structural racism around prenatal care. They are women who provide education during the prenatal period, who will go in and assist during birth. We do birth plans with families, and then we provide postpartum care and support, that time that is so critical when a lot of the things that we're talking about in terms of Black maternal morbidity are beginning and are happening after delivery. So they are a protective factor. We have trained Black women from the community. We have a training coming up in September with a goal of being able to provide a doula for every Black family who wants one. Again, centering in on where we see the most need. Doula collaboratives show evidence also for Native American and for Latina women. We have in our plans to replicate what we are doing with the Black Doula Collaborative for these other populations. We know that one of the key parts of the evidence in the Doula Collaborative is cultural parity. So we suspect, though we don't have any evidence, but strong hypotheses show that if we maintain the cultural parity, that we'll be able to do the same with immigrant and refugee women, which we also have large populations of in our community. So it is not that we're going to do the Black Doula Collaborative and call it one and done. We have a multi-year strategy to have other doula collaboratives and to, again, center in on the cultural parity, which is so important. We have a fatherhood program that is doing fatherhood education via Zoom and referrals and connections for dads. And there is another section of that. There are 8 workshops on the Zoom series starting this Thursday. We collect and report our data using the Peer Play system, which allows us to track the status of referrals that we're doing and ensure that people are getting connected to the services that we think that we're connecting them to. And so we have a data collection system called Peer Place. We do 3 signature events a year. Our Women's Health Day, Bear With Me, and an annual conference focused on an emerging maternal, paternal, child health issue that's happening in our community. This year, because of COVID, we've made the decision to not have these events, but we are already teeing up work for 2021. We have a community action network, which is meeting bi-monthly right now via Zoom, talking about all of the causes and drivers that we talked about on previous slides, focused on improving paternal, maternal, child health and birth outcomes in our community. And they are the origin of our fatherhood program, of our doula work, and of the way that our organization, Healthy Baby Network, has really done a lot of shifting over the course of the last year to be responsive to the needs that we're seeing with families. We have a quarterly networking session, which really is just about everyone come, share your agency or your program or your interest if you're a student and don't have an agency or a program yet. And then we share that information so that people have points of connection and places to start to build relationships. All of that information is on our website. We are starting a series called Challenging the Silence on September 15th. There are 5 discussions. This is not meant to be a lecture where I'm going to present a lot of tools. These are meant to be conversations where we center on these topics, talk about the issues that are surrounding them, share some resources, and ask the attendees, what work are you willing to do? What's your lane? What's your work? How do we help support that? And again, what are our connections so that we can build relationships? So with that, this is why it's all important. I love babies. We love babies. It's how we all got our foundation and our roots. And you know, the more that we center on the needs of our babies and their parents and provide the best care and the best support, the better we all are. This country, being very honest, got its origins on the backs of Black people and the bellies of Black women. That is a hard statement to make. I know that it creates some discomfort for people, but I'm willing to make it because it is so important that we understand what that contribution is to how we got here, so that we can craft great interventions about what we do about it, so that together we all move forward healthier and happier. And I truly believe that it is possible. I will stop talking my classic and then just stop talking. I have said all that I came to say today.
Bravo.
Bravo. Thank you, Sherita. And I don't want to go past 2. We're already way past 1:30, but I was not about to stop all of that great information that Sherita had to share. So we did get a question for you, Sherita, in the chat from Jillian. If someone is pregnant and is looking for a doula, who at Healthy Baby Network should they connect with? Or what number or what email should they contact?
You can contact our doula coordinator, whose name is Paula, and we try to keep our email very simple. So it's Paula, Paula, at healthy-baby.net.
Awesome. Okay, and unfortunately, we don't have much time for Q&A. There's just too much to talk about. This could be all day, multi-day conversation.
There needs to be a sequel. I think a sequel is in order.
That very well may need to happen, because that was too good and just not enough time. So if anybody has a really pressing question that they would like to ask and stick around for a few more minutes, ask it now. Otherwise, we are going to send a follow-up email in the next couple of days that will have a lot of resources and additional information for you to check out at your convenience to dig a little deeper into all of this. So if nobody has anything else right now, let's see, let me scroll down. Oh, Jillian said, are there openings for the CAN committee, Community Action?
Absolutely. So what I'm going to do is I'm going to put my email in the chat. And what I will say is you can email me anything and I will parse it out to the people. I will connect. Oh, okay, here we go. I was like, I don't know how to do this. Everyone. Here we go. So, Sherita at healthy-baby.net. And you can, like I said, email me anything and I will connect you to the staff person that it should go to. I've got to say hi to some of the faces that I know. Sean, it's so good to see you. There are many others who are here and who have been here. I just have to say hi and just acknowledge that you all are here. Oh yeah, I didn't put me on mute. I was making sure I wasn't on mute while I was talking to you all. But I just, again, want to thank Planned Parenthood. I think that this was such an important topic to have and to center on. And I'm so very grateful that you all did this. I'm so very sorry that I went so far over. I didn't have a clock, so I could not see
my
screen. But I really just appreciate you all being on and joining us as well. But again, thank you to Planned Parenthood.
Thank you so much.
Dr. Clark had to hop off the call. Very busy people, but we thank her too for joining us and sharing her expertise. So thank you to Dr. Clark, and thank you so much to Sherita for hopping on, sharing your work and your expertise with us. This is a really important issue that we all need to talk about. So the more conversations, the better. Like Sherita said, share this with people, share this with your friends and family if you learned something today. We will have a recording up online. I'm not exactly sure what that's gonna look like yet, but keep an eye out, and then you can share the recording with your friends and family as well. So stay tuned. This won't be the last time that we talk about this. So, keep an eye out for future programs. And keep an eye out for our email. And that's it. So I won't take any more of your time. Thank you so much, everybody, for joining us.
Thank you.
And enjoy the rest of your day. Bye.
Bye, everyone.
Thank you. Thank you all. And thank you, Sherita.
Thank you, Deborah.